Just let you know we're 2 minutes away from going live. Well, 2 minutes away from me talking. I'm going to go live in about a minute to let people in.
Raise my chair a second. Hold up. I'm just all messed up this morning. Maybe my big head will block the pictures. A little better.
Welcome to today's Power of Knowing webinar, The Death Experience Part 2. Understanding comes from knowing, and the diagnosis of a progressive or terminal illness can create a crisis for families and patients. This two-part webinar will explore the physical, emotional, and spiritual impact of illness on patients and families from earlier stages of illness up through death and bereavement. This free webinar series is called The Power of Knowing, which was created by AuthoriCare Collective, which empowers people to be active participants in their care journey, enabling them to live on their own terms through personalized support for mind, body, and spirit. To get us started, please welcome our moderator, Risa Hanow. Risa serves as clinical and community educator at AuthoriCare Collective and is also a member of the Cone Health Ethics Committee. She is a licensed clinical social worker. Risa, I turn it over to you.
Thank you, Paul. It's my pleasure to introduce our panelists for today. First, Whitney Blaylock. Whitney is a hospice home care social worker with AuthoriCare Collective. She is a licensed clinical social worker. Whitney has been with us for over 2 years and has worked in our palliative program and our hospice program. Whitney is passionate about healthcare and values the interdisciplinary team model. Stan Massey. Stan offers over 40 years of brand improvement and marketing expertise. He has worked on improving internal communications as well as creating marketing strategies and campaigns for more than 50 senior providers. In addition, Stan was the primary caregiver for Paula, his wife, prior to her death. Misty McAden currently is a chaplain with AuthoriCare Collective. She has been providing spiritual and emotional support to hospice patients and their families for over 8 years. Misty has a Master's of Divinity degree and is an ordained Quaker minister. Along with providing support to those facing life-limiting illnesses, she is experienced in providing grief support groups, workshops, and individual counseling. Allison Raver. Allison is a registered nurse certified in hospice and palliative care nursing. She has been with AuthoriCare Collective for nearly 5 years and currently is a hospice home care case manager. Allison helps families to anticipate and understand end-of-life changes and provides them with the knowledge and training to best care for their loved ones. And Victoria Thompson. Victoria is a Greensboro native and received her BSN from UNCG. Victoria joined AuthoriCare Collective in 2018 and has worked in our hospice program. Currently, she is a long-term care clinical manager. Caring for patients at the most vulnerable time in their life is her passion. Welcome to all of our panelists, and thank you for being with us. I also want to welcome you, our participants. We are glad that you are with us today, and we hope that you'll take a moment to answer a question that you'll see come up on your Zoom screen. It gives us a chance to know a little bit about you and the multiple roles that people tend to serve. So you can select all that apply to you. And this is anonymous, so we appreciate you taking a moment. It lets us know who is joining us as we begin our conversation. So that is always helpful for us to see and a way to get to know a little bit about each other in this virtual way that we have our conversations. So we'll take a look at the results of who is joining us. Not surprisingly, we have a really fair distribution of many caregivers, many advocates, healthcare professionals, human service professionals, and spiritual care guides. Welcome to each of you, and thank you for joining us today. As we begin our conversation, I want to invite you at any time to make use of the Q&A area on your Zoom screen and submit a question. We will do our best to answer as many of those as we can during our time together. And to get us started, Stan, last week you shared some about your and Paula, your wife's experience with her illness. And today we are really looking at the experience as somebody is nearing the end of their life. And I wonder if you could talk to us about that time, not just from Paula's perspective, being her voice as you are for us, but also for you as her spouse and also as her primary caregiver.
Yes, thanks, Risa, and hello, everyone. I don't know if you were able to join us last week, but just to recap, my wife Paula died of non-Hodgkin's lymphoma in 2013. And the 2 years leading up to that was really a steady decline for her physically and emotionally. As treatment after treatment failed to stop the cancer, she got increasingly more uncomfortable, even though she was receiving help from a palliative care team, which did provide really good support and helped alleviate some of the discomfort. Part of it was lymphoma is a very liquidy type of cancer. And she started to get a lot of fluid retention and swelling in different parts of her body, which made her uncomfortable. She wasn't comfortable sleeping in our bedroom anymore. And her days and nights kind of got flipped upside down. She was awake a lot all night long, didn't want to disturb me. So she asked me to drag a mattress out into the family room where a big TV was. So I did that. And really, we spent, a lot of time apart overnight. As her caregiver, I had to be in an adjacent room. And as I mentioned last week, during that time, you really sleep with one ear and one eye open and don't get a whole lot of rest. But in addition to her physical discomfort, Paula, I think, was really affected emotionally. And she was not an egocentric woman at all, but she did lose all of her hair because of chemotherapy. She started, getting swollen in different parts of her body, and she just felt unattractive, which I assured her was not the case. But it was almost as if she still wanted to look as best as she possibly could for me, which was totally unnecessary. But it was a concern, and it was a valid concern for her. She did buy some wigs that looked like her natural hair. And one of the highlights of those last 2 years was the Prince William royal wedding took place. And she got dressed up in her best wig and her best English hat and had a bunch of ladies over for a tea party to watch the royal wedding, which was really cool for her to be able to go through that despite her physical suffering. It really did help get her mind off of things for a day or so. So she really tried to hang in there emotionally. As the lymphoma spread, It actually got into her spinal cord and cracked a couple of her vertebrae, which made her extremely uncomfortable. It was painful. She had to have a clamshell type brace on her back to even get out of bed. So at that point, she couldn't really stay on the floor on a mattress any longer. Had to get the mattress back up to regular height on the bed frame. And every time she had to get out of bed, and a lot of times it was 2 o'clock in the morning to use the restroom, I had to cinch her into that clamshell brace as tightly as I could. And one time, despite her best efforts with a walker, she actually lost her balance and went down to one knee. And I was afraid to pick her up because she had cracked vertebrae in her spine. We had to call the emergency services department, and a couple of trained people came and helped get her back on her feet safely and back into bed. But there were just a string of incidents like that where her needs and her care became increasingly more intense. I mentioned last week, and this also progressively worsened or heightened. She wasn't really questioning. I don't think she was afraid to die. She was very at peace with her own spirituality and what would be next for her. But she was angry because she couldn't understand why a person like herself, who did everything right, ate extremely healthy, didn't smoke, drink, exercised regularly, really clean lifestyle, why it happened to her. And it was genetic. There was really nothing she could do about it. But it was hard for her to accept intellectually why she was going through that. It was tough for me to see her struggle with all of these aspects, physically, emotionally, and try to support her, in her spiritual beliefs, to find some comfort in that. So really my journey with her paralleled her emotions. The more she hurt, the more I grieved, the more I felt helpless. I did have support from our next door neighbor, who was her best friend. And her other friend happened to be a CNA, which was a godsend for help during the day. I mentioned last week that the end came very suddenly. She finally did sign on for hospice care. If she had signed on earlier, I think we could have gotten even more support, even just from a practical standpoint, like getting a hospital bed into the house instead of dealing with the mattress like I described, and other medical equipment. I mean, we did get support from the team with things like walkers and shower chairs and toilet chairs and things that really did make the overall care easier. But we really didn't enjoy that benefit for very long at all, because unfortunately, shortly after Paula signed on to be a hospice patient, she had a pulmonary embolism and died 36 hours later in a beautiful hospice inpatient unit. So I guess that's really just a quick overview of a lot of the aspects that affected Paula. A lot of it was directly related to the cancer, but things like her dealing with the changes in her body and making her feel unattractive, and just some other emotional things like that were as much a part of the journey and having to deal with than the physical side.
Thank you. Thank you both for being Paula's voice and also sharing your experience. And Whitney, when we think about disease progression and the decline and the additional needs that are often occurring for people, if you could tell us about hospice, the benefits of hospice, the team approach, and how there is help, as Stan mentioned, not just with the physical, but with the emotional changes, and help with difficult conversations and some of the things that can be very helpful as somebody is declining in their illness.
Yes, absolutely. Thank you, Risa. Again, I think Stan does such a good job of kind of capturing just exactly what hospice would hope to be in a scenario like this. So hospice is a team, and it's an interdisciplinary team for a reason, because we know that it's important to address symptoms of the patient, but also, everyone that is involved with that patient, able to support the family and caregivers as well. And so if someone is no longer seeking a cure and they've been, referred to hospice services and admitted to hospice services, then we're going to step in and address pain, symptoms, anything that may be, causing issues or making it so that they're not enjoying point in their life. And so we want to make sure that you're comfortable and focused on spending quality time. And so, like I said, we're supportive to the patient, but also to the family. And this is it's a collective effort from multiple members of the team. So you have a registered nurse, case manager that is assigned, and usually, their focus is symptom management, regards to pain, shortness of breath, a range of things that could come up in someone's illness. And so they're doing regular assessments of that and trying to monitor medications and making sure that we're communicating that with the family, but also with the rest of the team and the physician. You have a hospice social worker, and part of that role is dealing with, like Risa said, the difficult emotions, processing anything related to the illness or just in general. How are you feeling about where things are now? What's important to you? Let's talk about your goals for care, but also for your life, because we're involved with all of that at this point. Any resource needs, maybe talking about care needs in the home, just to support where you are in that moment. And then also, obviously, conversations about advanced directives or final arrangements if that's needed. There's also a counselor, a spiritual counselor, or chaplain. And a lot of times they're focused on the faith and belief of a patient, or maybe just some questions that may come up spiritually in regards to a patient or family's response to terminal illness. How are you coping with this? What questions might you have in relation to your faith or any spiritual concerns that come up? So they're another layer of support alongside of the social worker in the emotional aspect of that. And then you have the hospice aides. So they're fantastic of providing personal care to patients. And really, I think the empowerment piece of our hospice aides is unmatched because I think sometimes a lot of families and patients struggle to accept those services because it's intimate and you're bathing a patient because they're not able to do so any longer. And that's challenging to accept. But our hospice aides are phenomenal of making the patient feel empowered and really truly cherished and loved in that moment of providing that care. And it's, yes, like I said, it's unmatched there. And then you also have the hospice physicians and then your medical provider. They're still involved in your care. And so, you see that there's this team of folks that surrounds the patient and the family. And in surrounding that, we're not just talking about medically, how is this person doing? We're talking about everything. So what's your pain like? Are you anxious? How has your appetite been? Emotionally, how are you doing today? How are things going? What are you struggling with? And just offering support around all of that as a team. And I think that's what sets hospice care apart, because although we know, we're seeing changes and we see things progress and we're monitoring, the illness and how things are going to go in those last few weeks, days of life. But we're hands-on preparing and training the family to address that and support the patient, as well as supporting the patient in that process. And we couldn't do that without the interdisciplinary team.
Wonderful overview. Thank you. And it really highlights, the breadth of services that are available so that we can do anything possible to alleviate the suffering that is occurring both for the patient and for the family. And Allison, we know that oftentimes the unknown is so difficult. And we know that for many patients, not Paula necessarily, because her death came so quickly after coming on to hospice, but we know that there are often some common signs and changes that you as a nurse and other team members assess and observe. And I wonder if you could tell us about some of those more common changes that we observe as somebody is getting within weeks and days and even hours of the end of their life, and how you help educate the patient if they're able to receive that, and certainly the family members and the caregivers.
Absolutely, Risa. Thank you so much. So, to tap into what Whitney said, the training aspect and really understanding the changes that your loved one is going through it makes it so much easier. The title of this webinar is The Power of Knowing, and it's so right on, because knowing what is going on helps you through that process. Knowing how to respond to that and to best care for your loved one during that time is just amazing. And also to understand what could possibly happen. And the things that I'm talking about here, that's a large role in my part as the case manager. And I help the families on this journey understand what's currently going on, what they can do, and what to expect. Just to give a little brief summary to catch us up to where we are now. Up to this point, the loved ones have probably become more withdrawn from everybody around them. They're really going inside, trying to figure out what's going on and reflecting on their own life. They've already had a decreased appetite, and that's really hard to understand. And that's where I come in and help understand that they don't necessarily need that food at that time, sleeping a lot more, and really just not talking to others as much as they had been in the past. You may start to see, as things progress during the journey closer to the end, the patient may become more disoriented, confused. You may see them talking to people that aren't there, and that's hard to understand. We typically don't want a person to correct them because that's their reality at that time. You may start to see what we call restlessness or agitation, picking at clothes, picking at covers, just fidgety. Nothing's quite right. And as a caregiver, it's just overwhelming because you're like, what can I do? How can I make them comfortable? Because apparently they're not, based on what they're seeing with that restlessness. That's what I would do as a case manager, come in and help them understand that and treat it so we could calm that restlessness down so they could rest a little more comfortably. Some physical changes, there's quite a few that you may see closer to the end of the journey. Vital sign changes, of course, maybe a decreased blood pressure. A lot of my patients that are taking blood pressure medications, they typically don't need it close to the end. Pressure, it lowers on its own. Their pulse may increase or decrease. More often than not, I see it increase, and that's because the cardiovascular system is really pitching in to help everything else out. That's the way all of our systems do. They're pitching in, one trying to compensate and help the other. You may start to see some skin color changes. They might look kind of gray or pale, even bluish color. And families don't understand that. And again, I come in and let them know that's because the oxygen is not getting to those areas, and the circulation and the blood flow, all these things are slowing down. You may also see breathing, respiratory irregularities. I mean, some patients may have more labored breathing, rapid breathing, and others may have more shallow breathing. And even you start to see the onset of what we call apnea, which is going a period of time without breathing. And that's really shocking because families are like, whoa, what's going on? So I kind of let them know they may see that. So when they do, they're not shocked entirely. We often see congestion. It's a really loud congestion, and the families are concerned that they have this congestion is in the lungs, and it's typically not in the lungs. It's more, up here, just kind of settling at the base of the throat. And it's really loud because it's right there near the vocal cords. And this is all from the patient not being able to swallow very well. And even the saliva, they can't swallow that as well. So it kind of puddles right here. And then when they're breathing, that air through that liquid beside the vocal cords can make a really loud sound of congestion. And I have to just reassure the families, it's not in the lungs, given that it's not, more often than not, it is not. The patients are already sleeping more, but they're going to even more. They'll still wake up. You're still able to arouse them and get them to respond to you, but they're sleeping, my gosh, almost all the time. Sometimes only waking up to be fed. And speaking of food, at this stage, they're already eating a lot less. Their bodies are telling them they don't need it. Well, they may get to the point where they totally refuse food, and they're clear about it. They're just like, they'll either close their mouth real tight, turn their head, these types of things to communicate, I don't want to eat. And I have to let families know that it's okay. This is what we do see at this time, so we don't really want them to force food. We want them to listen to the loved one who is listening to their own body and what it's going through. There can be body temperature changes, which really, 1 minute they're hot, next minute they're cold. And, the loved ones are really wanting to make them comfortable. So, they're taking covers off, they're putting covers on. That too is part of this process. When their body's fighting, inside, that temperature could raise. And then when they're weak and they're needing that break, it could lower down. I just say, use a cool cloth to cool them off. On their forehead, nape of their neck, remove heavy covers, that kind of thing. And if you're cool, bundle them up. We just kind of adapt as it happens because it will fluctuate frequently, very often. As we move closer, you might see a period where all of a sudden your loved one they've got their energy back. They are more alert. They're talking to you more. They're more interactive. And it kind of gives a sense of hope. And I have to let them know, I have to let families know that more often than not, this is what we call just a surge of energy that they're getting, a rally, people may know it as. And it's a very brief period, and it soon goes back to where they were. You might really, after that rally, it lets you know it could be pretty close. So your loved one may really stop communicating, and they may have a distant stare and a glazed, glassy look on their eyes. It's kind of like they'll be looking straight through you versus looking at you. Communication will probably cease. They will continue to possibly see people that aren't there. More often than not, it is people that have already passed, loved ones of theirs that have already passed. And you'll see them reaching in the air and talking to them. And I see this so often, and I have to let families understand what is exactly going on. You may really start to see changes in the color of the hands and the feet, the temperature of the hands and the feet. They can be really cool to the touch, almost cold. The fingertips may get bluish in color. Their feet might start to get bluish in color on the bottom, purplish, blotchy, maybe even around the knees, and things like that. They often their urine output starts to slow down too. And of course, you've got decreased intake, there's going to be decreased output. But at the same time, their systems are slowing down. More often than not, they are incontinent at this time. They can't control their bladder or their bowel. So they do pee or have stool in the bed. But at that time, they'll have briefs, and the loved ones, we teach them how to take care of their loved one when they're in the bed. And it's a lot more responsibilities as caregivers that the loved ones typically take on because their loved one can't really take care of themselves anymore. They can't get up and get to the bathroom or the bedside commode. So you really have to take care of them. Then very close, I mean, right at the end, you might see some really breathing. It's kind of like a fish out of water. It's where they're just breathing rapidly and then slowly, and then, labored breathing. And again, that's what, at that stage, it's hard to really manage that type of breathing because it comes to a point where they do take their last breath. And it's a journey, and it's a journey that our body, it's a process that our body, it knows what to do. So we have to listen to the body. And based on my knowledge and experience, I help the families understand what's going on, so they can care for their loved one, and I can worry about their symptoms and take care of all those things, medications, symptoms, so they can just spend time with their loved one and feel confident that they are being taken care of. That's why it's so important to come on with hospice, as soon as your loved one is showing that decline, where they're having that functional decline, and that all efforts have been made to improve their status and it hasn't been effective. So hospice is definitely the way to go to properly care for them at that time.
Thank you. Thank you, Allison. You really laid it out beautifully. And to continue that, Victoria, as Allison spoke about the physical changes, and as we've heard from Whitney, we have this team, and a lot is on the caregiver. Now, it might be a family member, paid caregivers, long-term care facility staff, a combination. But we know that patient comfort and also preserving dignity, and also the caregiver being educated in how to safely care for a patient, so as to not hurt the patient, but also not hurt themselves. And that is really quite difficult. And tell us some about how you go about helping to aid people or guide people in the changes that are necessary in the care as somebody's decline occurs.
Absolutely. Thank you, Risa. You said 3 important words. You said comfort, dignity, and educating. Those 3 things that's our goal. That is our main goal as nurses, as we start to come in and see the patient. As the disease progresses, the body declines, as Allison discussed. They could get up and walk around, and now we are having to use a walker. Things that hospice will provide, but you go from being able to walk up on your own to using a walker to needing a wheelchair, and then eventually towards bedbound status, meaning you can't get up. In each of those states, it is our job as hospice and nurses, social workers, chaplains, to educate and reassure the family that this is the body's natural dying process. The body is declining. We meet you where you are. So the patient needs to learn how to use a walker. The family needs to learn how to use a walker as well, because they're going to be assisting the patient. In the facilities, we often, and I'm sure in the homes too, we often have to look at the room as a whole. Where is the patient going to be going with this walker? Let's declutter some things, get rid of that bookshelf that's been there, and we just keep bumping up against it. We want to make it as safe as possible. So as we use the walker, it's important to declutter. We think about fall safety, educating on how tall the walker should be, how short it should be. How do you walk with a walker? You've been walking by yourself all of your life. So that's a big milestone as the body declines. Then you may go to a wheelchair, whereas you need someone else to help you with the wheelchair. So now you're becoming completely dependent on someone else to push you where you need to go for the most part. So the wheelchair is a little bit bigger than the walker. So still just that safety aspect. And it becomes when I heard Risa say dignity, it becomes a dignity thing, because we still want to get to where we want to go. We still want to go and sit in the living room. We still want to make it to the bathroom as long as we can. So as we care for these patients, we're going to allow them to continue to do whatever they can do as safely as possible. That is our goal. Whether they're in the home, we want to keep them there, or in a facility. We want to make sure they're safe and make sure their dignity is shown. So in the facilities, they go to the dining room. So having someone sit in a wheelchair to go into a dining room, you know, everybody's looking, what's going on with them? What's going on with them? So we want to allow them to stand to like get dressed up like they were doing before, you know, put on a wig, you know, put on lipstick, put on makeup. We don't stop those things. Even though you're declining, we will continue those things up until the day you take your last breath, whatever the wish of the patient is. And I encourage families all the time, don't stop putting mother's lipstick on. Don't stop putting mother's socks on. Don't stop getting mother dressed, you know, all the way up until we go to get bedbound status. Now in the bed, there is another teaching mechanism that we have to do, a lot of position teaching. Body mechanics is important for family members, caregivers. We don't want to hurt our bodies, caring for our loved one, caring for our patients. So as nurses, we go in, we teach anybody that's going to be working with the patient how to safely do it so that we're saving our bodies as well. Even transfers from the bed to the wheelchair, or if the patient will just be staying in the bed, we can still make them comfortable. They can still eat in the bed, they can watch TV, we can put their head up or down. As Allison talked about, the breathing changes, it's important to be able to do those things. And hospice comes in and provides all of those assistive devices, the walkers, the wheelchairs, the hospital beds, bedside commodes, shower chairs, all of the things that you would need to be able to keep your loved one dignified, keep them comfortable, save your body as well. So it's all a process. And that is what I love about hospice and being a nurse. You can go in and educate. A lot of family members say, oh, mom's not wanting to get up today. It's all a part of the process. Even though she doesn't want to get up, it is okay. We can do everything that we would do getting up in the bed. We can still take a bath, we can get dressed, but it takes that education piece. So that is why I'm so glad that we as hospice can come in and teach you these things so that we can keep our family members going for as long as they can go.
Thank you. Thank you so much. It's I think it's reassuring because it's so overwhelming, not only to emotionally watch someone decline, but physically want to do the best. And so, Misty, all of this, of course, makes people grieve. Grieve as the patient for who they used to be and what they no longer are able to do. Family members grieving the loss of their loved one in the way that they knew them. And so we know grief is occurring during the decline. And we also know that then grief occurs after the death as well. And while that's a big and long process for people, I wonder if you could just talk to us about some particular things that you see and how you address them with patients as they're able and family members, both during the decline and then after the death for the family members.
I think that it's important to remember that the person may be dying, but they're also alive. And as Stan was saying, those things that can give them a moment of respite against thinking about, so that they're not thinking about death, what lies ahead. It relieves the anxiety. There's a lot of anxiety and impatience going on. The anxiety about what's going to happen next. Is this going to hurt? Worry about their family. There's a lot going on inside the patient's head, and there's a lot going on inside of the family's minds as well. Sometimes families want to push when, like Allison and Whitney and Victoria were talking about, they're pushing, trying to keep that person from experiencing that slowdown because the family can't accept the slowdown. They're not wanting to face it yet. And so there's a fine line, and there's a lot of emotion and grief that's going on. So like I said, each person is unique in their thoughts and emotions as they travel the journey. A lot of times at the end, you'll see people at the very end, you'll see the patient or the loved one who is passing sort of close in on themselves, sort of internalize and become more focused on something other than the environment. And that can be a little disconcerting for the family. There's also maybe there can be a sense of contentment or serenity, but there may be also a sense of, I want to fight this just a little bit more. And the family may feel like they're giving up if they're not assisting the patient in the fight. It's just that need to process. And then all of a sudden, after your loved one passes, you're not only grieving the loss of that person, you're grieving all the time, all the purpose, all the emotion that was put into that journey through that death journey, I guess is the way you could put it. You need to, and there's a need to be alone to process, but there's also a need to verbalize, because you're wanting to speak that story. And when we tell our stories, it strengthens our memories and builds them and gives us a clear picture in our minds and our hearts that we can carry with us.
Thank you. That really, I think, frames for us. And Whitney, I was going to ask you, one of the very unique aspects of hospice care is that when the patient dies, hospice services aren't over, because there are bereavement services for the family members. And you being a social worker and a member of the team, can you tell us about how that process works so that after a patient dies, we be sure that the bereavement team is going to become involved, and how patients can be reassured that their loved ones are going to continue to be supported by our organization, by hospice?
Yes, so we know that, part of our work is the caregiving part and preparing for a death. But after, we know that there is still work to be done. Families still have to process that loss and still have to, try to live in a world without their loved one in it. And a lot of times, I think the team is evaluating constantly how families are coping, how patients are coping, and we're thinking ahead as well. So we want to make sure that the families know that our care doesn't end once the person passes, that we also have bereavement counseling. And that looks like, the team will reach out after a death and just check in with the loved one, and also extend that kind of preparing them for a phone call from our bereavement counselor. And usually that can range from 2 to 4 weeks following the death, based on kind of the need that's identified. Or family members can request, they can say, hey, I think I need support sooner. And we will certainly connect them as soon as we can. And that role, can last typically up to 13 months after a death. That counselor can remain involved in providing support on a one-to-one basis, or also in group settings. And there's also kids path counseling. So when there are kids or children involved under 18 that have experienced a death, they can also have bereavement counseling through our kids path department as well.
Great, thank you. And Victoria, when we talk about dignity, I think about the dignity at the moment of death and the period just after the death. And I wonder if you could tell us about how you attend to a patient. You receive notification that the family or the caregiver believes that they have died, and how you go about verifying that, and then really caring for the patient after they have died.
Absolutely, Risa. So once we receive the call and we arrive to the home or to the facility, we are usually greeted at the door by the family member, or at the facility, we're greeted by the facility staff. Sometimes if we go into a facility, we may be there before the family arrives if they weren't there already. And we just ask the family if we can step into the room, and we assess the patient. We listen to their heart sounds. We see if they have a pulse. We look at their pupils. Those are some telltale signs that they have in fact passed away. At that moment, we go and ask the family if it is okay for us to go ahead and prepare the deceased body. When I say prepare, I mean we wash the body from head to toe. We make sure they are clean and dry, and we put on clothes of the family's choice if they would like for them to be dressed fully or in a gown or whatever they have chosen for us to place on them. We usually do all of those things in the home and in the facility, and then we ask the family would they like some time with the deceased patient. And at that time, we give them time if they would like some time. While they're spending time with the patient, we usually ask them about funeral homes, verify that. We always offer time for any other family members that are local that would like to come and see the deceased. We give time for that. There is no rush in anything, but we kind of step off to the side. We assess like how the family members are doing. Our chaplains and social workers are also available to provide that support, but we as nurses are there as well. So after we're done with the physical labor and giving them that time, then we can always sit and talk with the family and kind of see how they're doing. We do wait for the family to tell us when to call the funeral home. And when I say call, we go ahead and we call them to go ahead and come pick up the body, or we give them a time that the family may be ready, but nothing is rushed. We are all we allow the family to lead and guide us, but we do prepare the body as the family wishes. And that's kind of how it goes.
Thank you. And I think the patient and the family really, their voice matters. It is their story, and the respect for the wishes, whether it's religious, cultural, or family tradition, whatever the individual needs and wants are. So thank you for explaining that, because the reality of a death with hospice, where we're not having to call 911, or where we're not having sirens and having to be going to the hospital, and that part is something that we are able to help with in those conversations and the preparation of what is occurring as somebody declines. So thank you. It is hard to believe how quickly time has passed this afternoon for our conversation. And Stan, I want to come back to you. When you professionally have worked with many hospice organizations and care providers, so I know you have that professional lens. You also obviously have had the personal lens of being Paula's caregiver, and also grieving her death and continuing to live your life. And I wonder if you could share with us some thoughts and some hopes for all of us based on what your experience has been.
Yes, thank you so much. I would love to. By the way, I found on my phone, I hope you can see it. This is the picture of Paula on that day I was talking about.
That's wonderful.
In her best wig and hat, and her royal wedding party. She does not look like she's dying of cancer, does she? She was a warrior. She continued to live, absolutely. And one of the things, and I mentioned this last week, it is so important not to wait to get in touch with your hospice and palliative care team, no matter what the patient's condition at the time. We know that to get hospice care, you have to give up curative treatment, but you can get palliative care. And just getting in touch with your providers to find out how they can support you is so important. One of the biggest things, I think, with the anxiety and fear is not knowing what to expect next. And Allison did a really good job of describing how hospice professionals are able to tell you the signs and what to expect next. So it's not a shock. And there actually is a lot of comfort in knowing that. I really wanted to thank this team that's on this call today. We lived in Northwest Ohio near Toledo. So this is not the team that cared for Paula, but they were her counterparts. And just thank you for what you do every day, because it is such important work and so meaningful to families like mine. I have a really pretty cool ending to this story. So I mentioned that Paula passed away in an inpatient unit, and beautiful room, and a lot of family and friends had come to say goodbye. Her room was at the end of a hall, and adjacent to that room was this nice family, almost like a living room seating area, sofas and a kitchen and a TV. And you've probably heard a lot of times when someone passes away, and Paula was unconscious really those last 36 hours. She wasn't able to communicate with me or family members verbally. But I was watching her breathing go through the exact changes that Allison described. And the hospice nurse at that facility had also told me what to look for and expect. I've heard a lot of times that people who pass away actually wait until they're alone to do so. It's like, even though they're unconscious, they have some control on some level. So people have been in and out of the room all day. I saw her breathing getting slower and more shallow. And her best friend, the one who helped me take care of her, is a big coffee drinker. She said, you know what, I'm going to step out and go to Starbucks. I'll be right back. When she left, Paula's breathing got even shallower. And I took her hand and told her it was okay to go. I was the only one in the room, but my son and my stepson were in that family room adjacent. And both rooms shared a window that looked out on this beautiful courtyard that was surrounded by a fence. And I watched Paula take her last breath. And I knew when she exhaled that was it. And I'm not kidding. 10 seconds later, my son and stepson flew around the corner into the doorway of the room. And they said, did she just die? And I said, yeah, why do you ask? On that courtyard, it was a beautiful late March day, not a cloud in the sky, and there was no wind. That courtyard had a heavy wooden gate on the fence, and my boys were looking out, and that gate flew open, unexplained, and then slammed shut. And the only explanation I can think of, Paula was never subtle, was her showing them, I'm out of here and I'm on to what's next. It was really pretty cool.
That's beautiful. Thank you for sharing that. And I wonder if you're comfortable telling us about your journey after her death, and how you navigated that and where you are now.
Yeah, I would be glad to. Grief is very different for every person. And I think I came to find out that I was really grieving for over a year leading up to Paula's death. I did go to an official grief support group of spouses who had lost their husband or wife that was held through the hospice that took care of Paula. And I really did enjoy going to the meeting and commiserating with some others, but for me, I really didn't feel that I needed that continued support. That was a group that met twice a month, and it was open to me to go anytime I wanted. But I was at peace. I really was, especially with Paula leaving by the gate like she did. I knew she was on to better things. But I think that for me, for at least a year, it's just all of a sudden the person is gone, your partner in life, and you know it's coming. You can accept it, but you go home, and there's the cup that she just used less than 48 hours ago. There's her eyeglasses that she'll never wear again. It's tough, and I found myself going through waves of grief. And sometimes they would come totally out of left field. I mean, I'd just be hit out of nowhere and just start crying. And, I think that's common. So, as time went on, I think the frequency of those and the intensity of those diminished a little bit. It's been 10 years since Paula passed away, or just about. And, you can tell it's still very touching to me. But, I'm fortunate. I met another woman. It's a really interesting story that I won't go into today. But Paula was very philanthropic, and part of our life together was helping others. Paula was very entrepreneurial. She started a furniture bank in Toledo that allowed people that were coming out of social services programs to set up homes, or if they were getting out of prison or things like that. And so she really helped people get on their feet. Total nonprofit program. I met another wonderful woman named Catherine, who we have a nonprofit organization that serves Western North Carolina called Musicians Mission of Mercy, that brings food to people in need. And so I guess I have a type. I love compassionate women who like to serve other people. So I've actually continued on with my life, and I find it very rewarding and fulfilling. And professionally, I get to work with organizations like yours all the time, and using my personal experience, professional knowledge to really, when we talk about marketing hospice and palliative care, it really is more about educating, because there's so much that people don't know. So I find it very rewarding to do what I do and help communities throughout the nation get the understanding and the engagement with hospice and palliative care when they need it. And I am so honored to do so. But thank you for all that you do every single day.
Thank you. I think this opportunity of learning when we are not in the midst of crisis is so valuable. So I want to say thank you to each of the panelists, Stan, again, for sharing Paula with us and sharing your experience. And to each one of you, Victoria and Misty and Whitney and Allison, it is truly the team that makes the difference. And while you were spectacular panelists, it's really what you do every day when you are at the bedside and really attending and providing that compassionate and dignified care that I want to thank you for, and thank you on behalf of those that you provide that care for. I also want to thank our participants. This is a hard topic, so thank you for joining us and being with us. The Power of Knowing series is truly dedicated to providing information in the best way possible on topics that are most needed. So to that end, thank you for joining us, and know that tomorrow everyone will receive an email that will have a link to our website, and you can view this webinar again. You can direct others to watch it. If you weren't able to watch the first part, you'll see the recording there. And there is a library of past Power of Knowing, and we encourage you to keep your eye out for our next Power of Knowing. We're going to take July off, and we will be back in August with another program. But if there were to be any questions that you have, you can respond to that email that you receive, and I will get back to you with an answer just as quickly as I can. And you'll also see in that email some resources that you might find helpful along the day, along the way after our conversation. I always like to close with a quote, and this quote I think fits so beautifully with our conversation. And it's actually a quote from Dame Cicely Saunders. And Dame Cicely Saunders was the founder of the hospice, the modern hospice movement. And you will see that she had a deep understanding of this work. and we have the privilege of carrying it forward. And what Dame Cicely Saunders said is, you matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die. And so thank you again. Thank you to our panelists, and thank you for joining us. And we look forward to you joining us for future Power of Knowing webinars. And I hope that you each have a safe and good rest of the day. Thank you so much. Goodbye.